Hi students, welcome to the second part of the lecture over bone tissue physiology. I'm going to be talking about the process of bone development as well as the two major types of bone growth, which is intramembranous and endochondral ossification. Okay, so osteogenesis is the process of ossification, and that is just bone tissue formation. The stages of this bone formation begins in the second month of development. Postnatal bone growth occurs until early adulthood, and then bone remodeling and repair is actually a lifelong process. So, when you're just looking at an articulated skeleton or a model of a bone, sometimes it's hard to remember that bone is actually a living dynamic tissue. So there's going to be cells that of course have a shorter lifespan than we as humans do. So throughout our lives, we are going to be undergoing bone remodeling and repair. A lot of this is just going to be in response to stresses placed on our bones. And then for repair, of course, in the event of a fracture, we do have the ability to remodel and repair that area that was affected by the injury. So there are two main types of ossification. Intramembranous ossification is when bone develops from fibrous membrane comprised of mesenchyme, and mesenchyme it's a type of connective tissue and it is a tissue type that is common in undifferentiated tissues of the fetus, for example. So mesenchyme can kind of be the starting material for different types of mature tissues. And with intramembranous ossification, you have the formation of flat bones. For example, the clavicles, common name for those is collarbone, and then the cranial bones. So the frontal bone, parietal bones, occipital bone, etc. And then the second type of ossification is endochondral. And whenever you see chondro, think cartilage. So endochondral ossification is when bone develops from a pre-existing model of hyaline cartilage, and this is responsible for forming most of the rest of the skeleton. So everything aside from our flat bones, so bones of the limbs, for example, vertebrae, etc. With intramembranous ossification, as I've said, it produces the flat bones, and it also is responsible for thickening long bones throughout life. So even though we reach a point where our long bones are no longer growing in length, we still have the potential for those long bones to grow in width, often in response to stresses. So intramembranous ossification, we have the first step of that being deposition of osteoid tissue into embryonic mesenchyme. So this would be the mesenchyme. All of this kind of beige material is that undifferentiated connective tissue of the fetus. This would be a blood vessel here. The osteoid tissue is indicated in blue, and then the osteoblasts are these roughly square-shaped cells here. And remember, what osteoblasts do is they form the matrix outside of the cells. So they are going to be laying down collagen and the other material that is later going to undergo that calcification or mineralization process. So step 2 is going to be calcification of that osteoid tissue and entrapment of the osteocytes. So recall that once those osteoblasts have totally surrounded themselves by a matrix, that matrix becomes calcified. Once that occurs, those osteoblasts become osteocytes. And an osteocyte, that literally just means bone cell. So this is the mature bone cell that is within the calcified matrix. The third step is you have this honeycomb of spongy bone with developing periosteum. Periosteum will be that outer connective tissue sheath around bones. And then finally, filling of the space to form compact bone at surfaces, which leaves the spongy bone in the middle, which is depicted here. So that is intramembranous ossification. And this is a slide that actually shows this process in a real tissue. So the periosteum here, the fibrous layer, and then the osteogenic layer. Osteoid tissue is this layer here, and then osseous tissue. So this also points out the osteoblasts. So these kind of square-shaped cells here are going to be laying down the matrix, and then osteocytes, this would be a mature bone cell that is fully surrounded by this matrix. Endochondral ossification uses hyaline cartilage as a model. So remember that chondrocyte means cartilage cell, chondroblast is a cell that forms the mature cartilage tissue. So chondra has to do with cartilage, endochondral within cartilage, and this is responsible for the formation of pretty much all of our other bones. So we have this early cartilage model that's going to consist of hyaline cartilage. Second, we have formation of what's known as a primary ossification center, a bony collar, and the periosteum. So the primary ossification center is going to have basically stem cells that will eventually be responsible for forming this mature bone tissue. Third, the vascular invasion occurs. So we have blood vessels infiltrating into this marrow cavity. And then the appearance of a secondary ossification center. So right up here, secondary ossification center. Fourth, we have basically the state of the bone at birth with an enlarged primary marrow cavity, a secondary marrow cavity in one epiphysis. Remember that the epiphysis is the enlarged end of a long bone, and right here it's not too apparent that this is going to be an enlarged end, but in the mature bone that will be more obvious. Step 5, this would be the bone of a child with the epiphyseal plate at this distal end here, and remember that this is also just going to be cartilage. So it's going to be an area of hyaline cartilage that still has the potential of producing bone-forming cells, and that's going to help lengthen this bone. And then finally, we have the adult bone with a single marrow cavity and a closed epiphyseal plate, which is known as an epiphyseal line. So we still kind of see this vestige of where we had this growth in length occurring. So that is endochondral ossification, and again, that's going to be responsible for the formation of all of our bones aside from the flat bones. With bone growth and remodeling, this is a lifelong process. So bones are only going to increase in length up to a point. You're going to have interstitial growth of the epiphyseal plate, and then when the growth plates close, that's known as an epiphyseal line, and at that point the cartilage is gone and you no longer have the potential to increase the length of that bone. However, throughout one's adult life, bones can still increase in width, and that is known as appositional growth. Osteoblasts are going to be laying down the matrix in layers on the outer surface, and osteoclasts will dissolve bone on the inner surface as needed. So bones will remodel throughout life, and this comes down to Wolff's law of bone, which is simply stated, it says that the architecture of bone is determined by mechanical stresses. So if you are typically a very physically active person, or maybe have a job that requires you to do manual labor, your bones are going to be responding to that mechanical stress and will perhaps be denser and more robust than the bones of, say, somebody who has a more sedentary lifestyle. A couple images of fetal skeletons. So this is a fetal skeleton at 12 weeks. And bone formation, of course, has not completed at this point. You can see many of the bones, but they will not have their characteristic adult shapes. Obviously, they're going to be very small, and there's going to be a lot of cartilage filling the gaps between bones. You get a really good sense of the fact that the cranial bones have soft spots or fontanelles between them. And as the bone grows through intramembranous ossification, those soft spots are eventually going to be minimized. And in the adult, you'll just see sutures where those individual bones grew together. And an older fetal skeleton, I'm not sure the age on this, but again, you get the sense that you have bone growth still occurring, and remember that the flat bones of the skull, the clavicles, those are going to be formed via intramembranous ossification, whereas most of the rest of the bones are going to be formed through endochondral ossification. Okay, let's talk briefly about mineral deposition, which I've already reviewed this a little bit. So of course we have our osteoblasts. This is going to be a not very good depiction of an osteoblast, but we have our osteoblast with the nucleus and our rough endoplasmic reticulum. It's going to be blasting out those protein fibers, laying down all of that organic material. With mineral deposition, what we're talking about here is the process in which these organic fibers and ground substances are infiltrated by minerals that are ultimately delivered via the bloodstream. And those minerals are going to undergo this hardening process and create this mature bone tissue. So mineralization is a crystallization process. We have osteoblasts that are going to produce those collagen fibers. They're going to be spiraled along the length of the osteon. And remember that our osteon is basically the structural unit of our compact bone. So if we have our central canal here, our concentric rings, the lamellae, lacunae, with the osteocytes in here, there's going to be fibers that are laid down. And prior to mineralization, it's not going to have quite this neat appearance, but minerals are eventually going to cover the fibers and harden that matrix. And we have ions, which are calcium and phosphate derived from blood plasma, are going to be deposited all along those fibers. And there has to be a certain set of conditions met before crystallization can actually occur, called the solubility product. So the ion concentration must reach the solubility product in order for crystal formation to occur. And just as a reminder, it's been a little while since we talked about organic chemistry as it relates to A and P, but an ion is just a charged particle. So it's an atom that has either given up or gained electrons. So calcium ion typically is going to have a charge of +2. That means that it has 2 more protons than it does electrons. So a process that can occur with mineral deposition is abnormal calcification or ectopic calcification. You may have heard the term ectopic pregnancy, for example. Abnormal calcification can occur in the lungs, the brain, eyes, muscles, tendons, or arteries, in which case it's known as arteriosclerosis. So this is basically having this calcified hardened tissue where you're not supposed to have that. I've talked a bit about osteoclasts already. Recall that the osteoclasts have this really extensive surface area called the ruffled border, and osteoclasts are going to form from the fusion of multiple stem cells. So we have multiple nuclei here, and the more surface area of these osteoclasts, basically the more bone tissue that it can come into contact with. Getting a little creative or sloppy depending on how you want to look at it with the art here. But with mineral resorption, I believe I asked earlier kind of a rhetorical question, why would we need to actually break down bone tissue? So hopefully you've been thinking about that a little bit. One of the reasons that we need to resorb bone material would be, for example, if we have hypocalcemia, a low blood calcium level. Another reason would be perhaps if a fracture occurs and we need to break down damaged bone tissue. So we do have a supply of calcium ions that are freely exchanged between our bloodstream and our skeletal system. So with mineral resorption, we just have bone that's dissolved, and the minerals that were tied up in that bone material are ultimately released into the bloodstream and can be used elsewhere. So these cells that perform this duty are going to be called the osteoclasts, and that large amount of surface area on that side of the cell, that's called the ruffled border. And now how this occurs, there are actually hydrogen pumps within the plasma membrane of these cells that are going to pump out hydrogen into the space between the osteoclast and the bone surface. So basically this space in the margins between the osteoclast and this bone that will be resorbed, those hydrogen ions are pumped out into that area. And then chloride ions are going to follow by electrical attraction, and as a result you have the creation of hydrochloric acid, which has a low pH, pH 4, so it's acidic, and that is going to be responsible for actually dissolving the bone minerals. And then enzymes are going to digest the organic material of that bone, the collagen. So one of the ways that people take advantage of this natural process that occurs with osteoclasts is through the application of dental braces used to reposition teeth, and ultimately what we're doing is remodeling bone. So with dental braces, you're creating more pressure on one side of the tooth. That's actually going to stimulate osteoclasts to remove bone, and the decreased pressure on the opposite side is going to stimulate osteoblasts to lay down bone material. So in that way, you can essentially remodel little by little the bite of a person that may have an underbite or an overbite. Okay, so coming back to response to mechanical stress, something I've talked a little bit about previously. I've mentioned Wolff's Law. This just states that a bone grows or remodels in response to forces or demands placed upon it. And there are a number of observations that I wanted to bring to your attention that support Wolff's Law. One is the fact that depending on whether you're right or left-handed, the bones of the limb of that dominant hand are actually going to be thicker and stronger than the bones of the hand that you don't primarily use. Another fact that supports Wolff's Law, the curved bones are thickest where they are most likely to buckle. We also have trabeculae in spongy bone that form along lines of stress. And we tend to see large bony projections wherever there is going to be a heavy active muscle attaching to that bone. Okay, so I've arrived at the hormonal control of calcium balance. This is one of those functions of the skeletal system that is probably not super intuitive. People generally think of the skeletal system as kind of just being this static framework for the organs and muscles of the body, but we do have this exchange between ions in the blood and skeletal system. And there are a number of hormones that I'd like to mention that play a role in this process. So with this diagram, what this is basically showing is how calcium ions are exchanged between different parts of the body and the blood supply. So we have the blood supply here in the middle, we have the bone here on the right side, and then calcium intake and excretion is shown here on the left, which is going to be performed by your digestive tract and the kidneys of the urinary system. So arrows are basically showing the direction of calcium movement. So with calcium intake and excretion, we have a dietary requirement for calcium of about 1,000 milligrams a day. Fecal loss is going to occur on average in the amount of 350 milligrams a day. Urinary loss, 650 milligrams a day. And these arrows are basically showing how we harvest calcium from our diet and how calcium is going to be exchanged between the skeletal system and the bloodstream. So calcitriol, this is the most active form of vitamin D, and what this does is it increases blood calcium concentration. So as you can see here, it can increase blood calcium concentration basically by taking away from the bone. You see this arrow leading away from the bone to the blood supply. So how it does that is by increasing calcium absorption by the small intestine. So you see here calcitriol increasing calcium absorption by the small intestines, by the digestive tract. That's going to increase our blood calcium level. Also by increasing calcium resorption from the skeleton. Again, you're going to see that arrow going to the bloodstream from the bone. So increasing calcium resorption from the skeleton, and also promoting calcium reabsorption by the kidneys. So again, you're going to see that arrow leading away from the kidneys to the blood supply. So calcitriol, again, the most active form of vitamin D, it's going to increase the blood calcium concentration. With parathyroid hormone, or PTH, this is also going to raise the blood calcium level. And there are a number of different mechanisms that can occur here. You'll see PTH here. So again, arrow leading away from the bone to the blood supply, arrow leading away from the kidneys to the blood supply. That's telling you that PTH is going to be facilitating a higher level of blood calcium. So the ways that it does this, it increases osteoclast population. So remember that osteoclasts are going to break down bone tissue. If you're breaking down bone tissue, you are harvesting the minerals that were in that bone, and that can be released into the bloodstream. It also promotes calcium reabsorption by the kidneys. It promotes the final step of calcitriol synthesis, and it inhibits collagen synthesis by osteoblasts. So it inhibits bone deposition. So both calcitriol and parathyroid hormone are going to increase blood calcium levels. Now calcitonin is going to do the opposite. It is going to decrease blood calcium levels. And again, you're going to see an arrow, in this case, leading away from the bloodstream. Now, calcitonin is produced by the thyroid gland in what are known as C cells or clear cells. And it's going to be more important in children than it is in adults, but it's going to lower blood calcium by inhibiting osteoclasts and by stimulating osteoblasts. And one way that you might like to remember calcitonin, okay, this is silly, but if it helps you remember, that's going to be a good tool. Calcitonin, think tone it down. Blood calcium levels. Okay, so that is an overview of hormonal control of calcium balance. At first, this diagram kind of looks a little bit chaotic, but you just have to consider the movement of calcium ions, and you'll want to be familiar with these three hormones and basically how they help to regulate blood calcium levels and keep blood calcium levels in safe levels. Okay, I want to talk briefly about healing of a fracture. If you've ever had a broken bone, you know just how painful that process is. Luckily, we do have the potential to heal fractures, though. So what happens with a fracture is you have a break in the bone that causes small blood vessels to break and bleeding will occur, so bruising will occur as well. And whenever blood sits, it's going to clot. In this situation, we're going to call that a hematoma. A callus is going to form as a result of efforts from phagocytes, osteoblasts, and fibroblasts. Phagocytes, large eating cells, they'll break down cellular debris. Osteoblasts, those are those bone-building cells. And fibroblasts are going to be laying down proteins. A callus is going to harden to form new bone, and it's going to thicken based on principles of remodeling. So step one after a fracture occurs is going to be the formation of a hematoma. You have blood clotting occurring where this break was due to breaks in the blood vessels. Step two is going to be a fibrocartilaginous callus is going to form. Step three is going to be a bony callus form. So we have ossification of the tissue that's laid down here. And then finally, bone remodeling occurs. And oftentimes you're going to have some signs of where a fracture has occurred in the past. There might be a slightly altered appearance to the bone, a slight thickening where that fracture occurred. There are a couple of homeostatic imbalances that I would like to mention as well. Osteomalacia, as well as rickets. This occurs when calcium salts are not deposited as they should be. Rickets is really a disease of childhood, and it causes bowed legs and other bone deformities, just because you don't have the proper amount of calcium for bone growth. And ultimately, your cause is going to be a vitamin D deficiency or insufficient dietary calcium. And then osteoporosis, fairly common disease of later adulthood, particularly in females. This occurs when you have a loss of bone mass whenever bone resorption outpaces deposition. And typically you have the spongy bone of the spine and the neck of the femur that are most susceptible to fracture. So the neck of the femur is going to be a fairly narrow portion between the diaphysis of the femur and part of the epiphysis, the head of the femur. This is supposed to be more round. But this is the ball of the ball and socket joint of the hip, and the neck of the femur is right here. So this is very susceptible to fracture just because it is a fairly thin bridge of bone, basically, and it's supporting a lot of the body's weight. And some risk factors for osteoporosis, going to be a lack of estrogen, calcium, or vitamin D, petite body form, immobility, so being more sedentary, maybe not exercising, certainly not doing weight-bearing exercise, for example. Low levels of thyroid stimulating hormone, or TSH, as well as diabetes mellitus. And this, of course, is going to be normal bone, so it's showing the trabeculae within spongy bone. Osteoporotic bone is basically going to have this kind of broken down, just less robust appearance. And for treatment and prevention of osteoporosis, there's a number of things that can be done. Calcium, vitamin D, and fluoride supplements. People who are at risk of osteoporosis are often recommended to start weight-bearing exercises throughout their life, just to basically try to build up bone density. Sometimes hormone replacement therapy can slow bone loss, and then some drugs can also increase bone mineral density. Okay, so that's going to wrap it up for my lecture on bone tissue physiology. As always, please let me know if you have any questions, and thank you for listening.